Welcome to part 2 of 2 presentations on the chest. If you haven't already reviewed part 1, it might be a good idea to do so. Okay, so there's lots coming in this video. First of all, we'll start off with alveolar versus interstitial disease. Then we move on to pneumonia, pleural effusion, pericardial effusion, pulmonary edema. We'll look at a few different types of lung masses, TB, subcutaneous emphysema, perforation and pneumo-peritoneum, and then we'll finish off with some anatomical variants which will be of interest, we hope. We hope you enjoy.
Let's talk about the alveoli and the interstitium. The terminal bronchioles, they give rise to alveolar ducts, and these then terminate into small air sacs. Now these air sacs are called alveoli, and they're responsible for gas exchange. So carbon dioxide goes out and oxygen comes in. Now the interstitium, it surrounds the terminal bronchioles and the alveoli. And this is an important mechanical function because it acts as scaffolding to support the alveolar walls. The interstitium also has a very dynamic function because it allows fluid, cells and nutrients to pass in and out of the interstitium. Alveolar disease, interstitial disease, consolidation and pneumonia, they're all very closely related. So alveolar disease is an airspace disease. And what happens is that the filling of the alveolar spaces with abnormal material. Now this abnormal material can include transudate, pus, blood, cells, protein, fat, gastric contents or water, or any combination of these. This little table outlines what can cause the product building up within the air spaces. So interstitial disease, this affects the supporting tissues of the lung parenchyma. So basically, the interstitium, including that surrounding the alveolar walls, is affected. An insult causes the cellular lining of the alveolar walls and/or the capillaries in the interstitium to become leaky. So this edema that leaks out accumulates in the alveoli or the interstitium. Now sometimes the injury progresses to cause extensive necrosis with production of fibrin and cell debris. So these necrotic products, they fill the alveolar air spaces or they thicken the tissues of the interstitium. If you see diffuse shadowing, whether it be localised or widespread, then you need to assess the pattern to work out if it's alveolar disease or interstitial disease. So alveolar changes, the appearances are fluffy or bobbly, ill-defined margins, they coalesce or they merge. You may get segmental or lobar appearances. You may get air bronchograms. Interstitial changes are small nodules. They're linear or reticular. You get what's known as curly bee lines. And then reticulonodular. So let's look at the difference between alveolar disease and interstitial disease radiographically. If you remember from the slide before, air bronchograms appear with alveolar disease. So what do I mean by an air bronchogram? So what happens is you have these larger fluid-free airways and they appear dark against the background of the white outer lung. in comparison to interstitial disease, which have curly bee lines. So what are curly bee lines? So these are fine, horizontally orientated lines. They're roughly 1 centimetre long and they're situated perpendicular to the lateral pleural space. Most commonly, they're seen just around the costophrenic angles. Remember, radiographically, your costophrenic angles should be clear. So if you have prominent lung markings in these areas, then interstitial disease at the lung base is likely. Pneumonia is inflammation. It's usually due to infection and involves the alveoli. Pneumonia is the most common cause of consolidation on the chest X-ray. Lobar pneumonia is when a large part of the lobe is affected, and it may actually involve the entire lobe. So therefore, if it's lobar or segmental, it's alveolar disease. So let's have a look at this image. Which lobe's affected? Let's think back to our silhouette sign. The right diaphragm is clearly demonstrated. So therefore, it can't be involving the lower lobe. Now let's look at the heart border. Yeah, we can clearly demonstrate the heart border, the right heart border. So that's not the middle lobe. Now let's have a look at this. This consolidation is superior to the horizontal fissure. And so therefore, this is the right upper lobe. Okay, so what have we got? Consolidation. Where? Right upper lobe. How? Lobar. The pleura is composed of a very dynamic membrane of mesothelial cells and a deeper layer of connective tissue. And this contains vessels, nerves and lymphatics. So this membrane responds very actively to inflammation with the accumulation of fluid. So think of heart failure and the accumulation of fluid within this area. Now there are several very different appearances of pleural effusions. The most common one that we see is this opaque meniscus at the costophrenic angle. However, it takes 200 to 300 millilitres before we can actually see this effacement of the sharp recess between the diaphragm and the ribs. If the effusion is really large, then the entire hemithorax may be opaque and the heart may be pushed towards the normal side. There are 3 other patterns. Lamella, which is a linear shadow that parallels the lateral aspect of the lung. Encysted, so you get an inoculation within the fissure or somewhere else. Subpulmonary, this is where you get pooling within the pleural space below the lung. Now this is usually easiest to detect on the left, because what will happen is the pool will cause the gastric bubblet to be widely separated from the superior margin of the diaphragm. Remember, the difference of more than 3 centimetres between the left inferior hemidiaphragm and the right hemidiaphragm is abnormal. So this will suggest that there's a subpulmonary effusion. So here we have a moderate right-sided pleural effusion. We've lost the costophrenic angle and the cardiophrenic angle. We've lost the silhouette of the right hemidiaphragm. Therefore, this must be within the right lower lobe. We have a curved meniscus that's seen laterally and it gently slopes medially. So what is it? It's a pleural effusion. Where? Right lower lobe. How? Moderate. We've got a lot going on this X-ray. We've got an enlarged heart. They've had previous heart surgery. But what I want you to focus on is this encysted pleural effusion within the right horizontal fissure. What is it? It's a pleural effusion where horizontal fissure, how encysted. Here we have a great example of a subpulmonary effusion. So remember, our left hemidiaphragm should be slightly distal to our right hemidiaphragm by 1 costal interspace, which is about 2 centimetres. Anything greater than 3 centimetres needs to be considered as abnormal. But the real clue is the location of the air bubble within the gastric fundus. That should be just inferior to the left hemidiaphragm. And therefore, this means if we can't see the left hemidiaphragm, there has to be fluid collecting in the left lower lobe. So what is it? It's a pleural effusion. Where? Left lower lobe. How? Subpulmonary. Your pericardium is a conical flask-like fibrous serous sac. It contains the heart and the roots of the great vessels. Now your pericardial space is between the parietal and the visceral layers of the pericardium. And it usually contains about 15 to 20 millilitres of fluid. So pericardial effusions occur when there gets an excess of fluid and it fills up within that pericardial space, and so you get this really globular enlargement of the cardiac shadow, giving you kind of a water bottle configuration. Now clinically, the size of the pericardial effusion is actually less important than the speed of the effusion. So if you have a slow gradual accumulation that allows the pericardium to stretch and accommodate much larger fluid, that's actually less clinically significant than something that grows very quickly. So what is it? It's a pericardial effusion, where the pericardial space and how it's large. So pulmonary edema is a fairly broad term, and it's usually defined as an abnormal accumulation of fluid within the air spaces or the parenchyma. Now it can have a dominant alveolar pattern, or it can have a dominant interstitial pattern. Or just to confuse things, you can have a mixed alveolar and interstitial pattern. Now it may be due to cardiac causes such as left heart failure, or due to non-cardiogenic causes such as fluid overload, acute asthma or ARDS. Pulmonary edema impairs gas exchange, and unfortunately this may lead to fatal respiratory arrest or even cardiac arrest. So here we have a mixed pulmonary edema featuring both alveolar patterns and interstitial patterns. So remember, our alveolar patterns are fluffy and bobbly. We can see that up here. These are white arrows indicating the fluffy, blobbly shapes. But if you look much lower down, we can see our tiny horizontal lines which are located around the costophrenic angles. What are they called? That's right, curly B. And our curly B lines are associated with interstitial pulmonary edema. So we have both alveolar patterns and interstitial pattern for this case. So what is it? It's pulmonary edema. Where? Left and right lungs. How? Mixed alveolar and interstitial. Lung cancer is the third most common cancer in the United Kingdom and the second most common cancer of males and females, with breast being the most common and prostate the second most common. Lung cancer, unfortunately, is the most common cause of cancer death in the United Kingdom, and the solitary pulmonary nodule is a very common finding. So let's have a look at that radiographically. So How can we tell whether something's aggressive or benign? So when you look at a solitary pulmonary nodule, if it's less than 3 centimetres, it's probably benign. If it has very smooth margins, again, it's most likely benign. Unfortunately though, if it's metastatic, that's not so true. If you have a lobulated or scalloped border, then you have an intermediate probability of malignancy. Solitary pulmonary nodules that are greater than 3 centimetres with an ill-defined border are most likely malignant. And those with the cavitating masses are highly likely to be malignant. Let's look carefully at this X-ray. We can see a solitary pulmonary nodule hiding behind the heart. Unfortunately, our heart is an area that is frequently overlooked on the X-ray. What you want to be looking at is to be comparing both the left border of the heart with the right border of the heart. Unfortunately, the right border is not very well clearly seen, but they should be of a similar density. If you have an area of increased density, that indicates an abnormality. So when you check your heart, compare both sides to see if they have a similar density. So what is it? It's a solitary pulmonary nodule. Where? Left lower zone. How? Small. Now let's have a look at this X-ray. We can see bilateral solitary pulmonary nodules. Or are they? As we get older, our nipples become more dense, and so these are actually dense nipple shadows. If you take an X-ray and you see a dense nipple shadow, you must repeat using nipple markers, because this will really help the reporter to be confident that this is just dense nipples and not a solitary pulmonary nodule. Unfortunately, some tumours will hide, and unfortunately the lung apices and hiding behind the clavicles is an absolutely classic location. Equally, the overlap of the first and the second ribs can cause some confusion. So a Pancreas tumour is a tumour of the superior sulcus, and so what you're going to get is a dense soft tissue opacity within the apex. Unfortunately, sometimes you can get rib involvement, so you'll get bone destruction. So check the apices. Do they appear the same density? If not, then you need to be concerned about a Pancreas tumour. So what is it? Pancreas tumour. Where? Right apex. How? Large. So multiple pulmonary nodules is unusual. So the default diagnosis is going to be METs. So the big common ones are breast, colorectal and renal cell carcinoma. And usually they tend to be well circumscribed, rounded lesions, and they're usually on the periphery of the lung of varying size. All around here, just everywhere really. Now some tumours have a predilection for innumerable small metastases, and this is described as a miliary pattern, and that's usually from thyroid. Now some can be really large, well circumscribed, with a rounded pulmonary mets. And these are classically called cannonball metastases from renal cell carcinoma. Okay, so here's a classic appearance of miliary metastases. What's that caused by? Yeah, most likely thyroid. So round, absolutely multiple all over. So what do we have? We have metastases where left and right lung how miliary. Here we have our classic cannonball. So these are really large, well circumscribed mets, which is usually caused by renal cell. So what is it? It's metastases where? Left and right lung. How? Cannonball. So pulmonary tuberculosis has different chest appearances for primary tuberculosis and post-primary tuberculosis. Now our post-primary tuberculosis is categorised on cell reactivation of tuberculosis, usually within 2 years from the initial infection. I'm going to focus on the appearance of post-primary tuberculosis because I want you to get used to the classic appearance. So what you get is this consolidation with or without cavitation, and it's usually within the apical or posterior cell segments of an upper lobe. So this is a very classic example of pulmonary tuberculosis, and I would like you to focus on just this appearance. So what is it? It's pulmonary tuberculosis. Where? Right apex. How? Segmental. Subcutaneous emphysema is when air or gas is located within the subcutaneous tissues, and it frequently occurs in the chest, face or neck. And if you actually palpate it, you can have this kind of like Rice Krispies feel, the crackling and the popping. Now it can be due to penetrating trauma, or it can be due to post-surgery or from tracheobronchial perforation, and then you get this gas tracking. So radiographically, we get this air trapped within the soft tissues, and it might create slightly odd appearance with streaking of gas over the overlying structures. Free gas under the diaphragm is a classic sign of pneumo-peritoneum on the erect chest X-ray. However, in clinical practice, you've just got to be careful that it isn't due to recent surgery, peritoneal drains, dialysis catheter, or increased airway pressure for ventilation. However, if you see this appearance in the exam, then you would attribute it to pneumo-peritoneum. So we can clearly see the air trapped under both hemidiaphragms. So what is it? It's a pneumo-peritoneum where the abdomen, how free air is seen under both hemidiaphragms. The chest, as with all other anatomical locations, has anatomical variants. Dextrocardia is something that we need to be aware of. It's a congenital cardiac malrotation, so the heart appears on the right and the apex of the heart is pointing to the right. Now it's believed to affect about 1 in every 12,000 births. The most important thing is to note that the air bubble within the gastric fundus is situated on the left, indicating that only the heart has malrotated. So what, where and how? Normal study, Dextrocardia noted. This is Dextrocardia situs inversus totalis. This is a much more significant finding. So what happens is that you've got dextrocardia of the heart. We can see the heart is clearly on the right, apex pointing to the right. But also, if you look, the air bubble within the gastric fundus is on the right, and then our liver is situated on the left. So you've got complete transposition of right to left reversal of all the abdominal organs. And this has a really significant complications for this patient. You can see they've got really enlarged heart. So what is it? It's Dextrocardia situs inversus totalis. Where? Right. How? Dextrocardia and complete transposition of all the abdominal organs. The azygos fissure is the most common accessory fissure. It usually occurs in around about 1 to 2% of individuals. Our azygos vein is horizontally located along the right side of the mediastinum. It hooks forward over the right main bronchus, and it drains the azygos system into the superior vena cava. If there's an azygos fissure, then the vein is surrounded by both parietal and a visceral pleura. So you've got these 4 layers of pleura, and they wrap around the vein, and it gives it a bit of a tadpole appearance. What I want you to recognise in comparison to the pneumothorax, which is on the right, is that the azygos fissure curves medially in the opposite direction of the apex of the lung. So this is in comparison to our pneumothorax, which follows the curvature of the lung. Let's look at that in a little bit more close up. So here we have our azygos fissure curving medially, and on the right we have our pneumothorax, where it follows the curvature of the lung. What, where, how? Normal study, azygos fissure noted. Pectus excavatum, or funnel chest, is a congenital chest wall deformity. So you get this characteristic depression of the sternum. So on our PA view, our posterior ribs are horizontal, and our anterior ribs, they're heart-shaped. You get this blurring of the right heart border, and this mimics right middle lobe pathology, and our heart is displaced off to the left. So what, where and how? Normal study, Pectus excavatum noted. So you can use a 10-point checklist to make sure that you've assessed all of the chest. 1. Look at your trachea, is it deviated? Assess the whole lung fields. Is one lung whiter than the other? I want you to check the hidden areas. So remember the apices, are they a similar density, or is one more indistinct than the other, which might indicate that you have a Pancreas Tumor. Check to see if you can see a silhouette sign. So this will tell you if you have a specific lobe pathology. Is your mediastinum and heart enlarged or displaced? Are your fissures in the normal location, or have they shifted? Are the hilar in the correct location, and are they of similar density? So remember, your left hilar is higher than your right, and they should both be of a similar density. Lumpy, bumpy hilar indicate an underlying abnormality. Can you see the diaphragm? And look below the diaphragm. Do you have a subpulmonary effusion? Remember, check your bones for fractures and destruction indicating a tumour. Are your soft tissues normal? Do you have bilateral breast shadows? Are there any abnormal densities? Check behind your heart. Make sure there isn't a solitary pulmonary nodule hiding there.